Welcome to today's webcast, which is brought to you by our sponsor, SelectWell. Today's event is Firefighter Heart Health in the age of COVID. Now, most chronic diseases are detectable and are best prevented years before they're diagnosed. SelectWell offers comprehensive and advanced diagnostic testing focused on early detection of chronic diseases. Accurate and understandable diagnostic lab tests are critical for preventative medical management, potential reduction of disease, and to ultimately improve health outcomes overall. SelectWell's mission is to support the growing community of disease prevention and disease management focused employers and employees through an effective personalized disease management and prevention programs. The SelectWell Firefighter Heart Health Program provides the most current, reliable, scientifically advanced laboratory testing, personalized lifetime tracking, clinical expert guided education, as well as individualized health coaching. Now, a little bit about today's presentation. It's both live and interactive. You can ask questions at any time by just clicking in the Ask a Question widget in the presentation window on the left side. If you have any technical difficulties, just alert us through the Ask a Question feature, and a member of the support team will work with you to fix the issue. Today's webcast has a certificate of attendance, but to receive it, you've got to hang on until the very end. You should receive the certificate within 24 hours. On-demand viewers, please just email us at webcast@clarionevents.com. We recommend that you close down all other applications for better performance during the webcast. Now, this presentation will be available on demand within 24 hours of the live event, and we will send a reminder email message to everybody who registered with a direct link to the archive, but you'll also be able to find it for a year on fireengineering.com should you wish to rewatch it. So folks, please take it away.
Thank you. Good morning or good afternoon, depending on where you are. Welcome to Firefighters Heart Health in the Age of COVID. I'm Brenda Superko, and I'll begin our presentation by sharing who and why we're presenting to you today. I'm a cardiovascular nurse with a strong focus on prevention and education. I'm currently the clinical educator for the SelectWell Firefighter Heart Health Program. And while I've had many great mentors in my career, none have been better than my husband and co-presenter today, Dr. Robert Superko. Physician, researcher, academic, and educator, Robert is considered one of the pioneers in applying research discoveries to both personalize and improve upon cardiovascular health. He has been recognized and honored many times in his career, but I can assure you, I choke up at that. No, I can assure you, nothing means more to him than working with the firefighters. So our presentation today is going to highlight the FEMA funded grant, a heart disease prevention study that Robert wrote and conducted in Gwinnett County firefighters. This study was born out of the local evening news with the then Gwinnett County Fire Chief, Steve Rollator. Chief Rollator was expressing concern over firefighters dying, not from injuries, but from heart attacks. The topic was not lost on us, but it offered us an opportunity to give back, doing the only thing we know how. Robert and I were in New York on 9/11, and we knew that while we and thousands of others were panicked and escaping, there was only one group of professional, highly skilled, and very brave entering into those twin towers. After the FEMA study was completed and published, Robert presented the scientific findings at International Association of Fire Chiefs meetings, as well as numerous medical conferences across the US. Together, we have advocated for and performed numerous firefighter heart health screenings. We have asked Monterey City Fire Chief Gal Des Panholzer to join us today and speak to our local efforts with fire screening, as well as COVID testing among his firefighters there in Monterey. Thank you, Chief.
Thank you, Brenda and Dr. Superko for inviting me to participate today. Several years ago, for the audience, several years ago, Dr. Superko reached out to me, having recently moved to the area where we are here in California, and explained a little bit about his background in the study that he had done, and that he was interested in conducting a study on our firefighters here in Monterey. We do an annual medical screening of our firefighters per NFPA, and so we do get some cardiac feedback on that. But as Dr. Superko related to me, that's not the tests that we do are not necessarily as thorough and complete as they can be. So working with him, we put all of our firefighters through a cardiac screening. And lo and behold, I had a few folks on the department that were able to find out that they had some extenuating risks and were able to take some positive action to mitigate those risks and minimize them before they became a problem. So it was a really, really great tool. Our relationship has continued since then, and with the advent of COVID, he reached out to me again and said that he wanted to do something to support us through that. And we were able to set up a regular COVID testing through the Superkos. They came to the department and set up shop here several times to conduct tests of firefighters to monitor our staff before testing was regularly available out for the general public. So it's been a great relationship, and I know that his impact and Brenda's impact have made a difference in some of my personnel's lives. And so I really appreciate their efforts and being able to be part of this program today. Thank you.
Thank you, Chief. Well, my next introduction is Dr. Kayvon Ettava. He is a lab director at Salap Lab Partners. Our lab is actually located in Greensboro, North Carolina. This lab specializes in performance of both reference and advanced testing, and Select Lab was early on in providing COVID testing, both antigen and the gold standard PCR testing, to businesses and firefighters across the U.S. Dr. Ettava will present the Firefighter Heart Health Program and share the personalized and HIPAA-compliant platform in which firefighters can receive and schedule a consultation of their results. As medical professionals, we understand there is almost no value to just providing you with a lab test. Disease risks need to be understood and personalized, actions guided. So just as Robert and I may have suited up and gone into the Gwinnett County Fire Academy for a burn, we know we can't begin to understand and comprehend what you do every day professionally. With this same complexity of heart disease and COVID, we're here to help you understand and guide you and hopefully give you a glimpse into what a firefighter-specific heart health program should look like.
So this is going to be our agenda for this morning. We're going to talk about firefighters' heart disease risk in the age of COVID, particularly in regards to the extent of the problem, how severe is it, and why should you pay attention to it. Then we'll talk about some concepts of heart disease, which may or may not be familiar to you. We'll review the lessons we learned in the FEMA study, and then Brenda will discuss the vulnerable firefighter concept that is important in terms of detecting who might have underlying heart disease and who you need to pay most attention to. And then finally, we'll talk about the Firefighter Heart Health Program that we're making available to fire stations across the country.
So as you know, firefighters, and we're preaching to the choir here, firefighters have 2 to 3 times the amount of coronary heart disease and sudden cardiac death compared to other professions. The evidence proven in the FEMA study, as well as others, showed us how best to identify firefighters that are most vulnerable to heart attacks and sudden cardiac death. The solution, we hope you will understand by the end, the FEMA study actually did what, 500,000 tests. So we looked at a lot of tests, genetic tests and other markers and imaging. We hope by the end of this presentation, you'll better understand which specific heart health specific test we are bringing to you today.
So the extent of the problem is illustrated by this slide. This is showing during emergency duties, when a firefighter died, what was the cause of death? And if you look at that blue area, that's death due to heart attack. Almost 52% of the deaths during emergency duties and firefighters occurred because of a heart attack. Trauma there in red at 24% is also clearly important, but it's important to appreciate that of all the risks firefighters face in terms of dying, heart disease leads the way. And that's why we've developed this program. So sudden coronary death is what SCD stands for. And we know from multiple studies that it occurs in firefighters who already know they have cardiovascular disease. Well, that makes sense because if you know you have heart disease, it's likely that that's what's going to get you. But number two, it was also found in firefighters who had cardiovascular disease that they did not know about, but actually had cardiovascular risks. So the program is designed to identify those. And finally, in individual firefighters with undiagnosed heart valve problems, that was a cause of sudden coronary death as well. Often that's genetic. So autopsy studies have been performed on firefighters. And the three important findings is number one, they have plaque in their arteries. That's the buildup of cholesterol and fatty material in the coronary arteries. So that is coronary artery disease. Number two, they have evidence of an acute coronary artery occlusion, a sudden blockage of the lumen to obstruct blood flow to the heart. And number three, they may have had some pre-existing heart muscle damage, such as that caused by hypertension, resulting in left ventricular hypertrophy.
So as we are speaking to you today, all of you are aware of COVID. The numbers are big. It's a pandemic. I know we all know that by now, but what you may not know is the reality of COVID comorbidities and cardiovascular share many risks. So while as of today, we have already lost over 850 people in the United States, 850,000, thank you. See, this co-presenting helps. 850,000 deaths in the US. And while we can say that we have over 800,000 new cases reported daily, I think all of us can say that's probably an underestimate because how many people are struggling to get tests available today. And our hospitalizations are back up, and depending on your area, your part of the country, right now we know that we have at least 160,000 people admitted to the hospitals with COVID. So while the majority of these hospitalizations and deaths, severe disease and deaths, are occurring in the non-fully vaccinated and in those with underlying cardiometabolic health risk. So the solution we want to offer is to vaccinate plus boost, but most importantly to monitor and improve your cardiac metabolic health.
So this just came out and I had to make a slide of it and include it today. And it's looking at the dramatic increase in hospitalized cases in New York City at the top and down below that in Seattle. And there's two groups of people. The gray line are individuals admitted who are vaccinated, and you can see there's a slight uptick. The red line are not fully vaccinated individuals, and that's where the problem's occurring now. People who are not vaccinated, who are going through an acute problem, but there's also chronic problems that result from this infection, such as known as the long hauler syndrome. So the big problem we have now in terms of hospital stress is the not fully vaccinated individuals.
So we want you to understand what some of these shared risks in these, you may have heard it referred to as comorbidities, but those are overweight and obesity, diabetes, or the metabolic syndrome, pre-diabetes, type 2 diabetes, and we're going to go into more detail on these soon. Hypertension or unmanaged high blood pressure, an increased risk for blood clots. This has been a big factor in those who have been diagnosed with COVID, and inflammation. The root of a lot of health issues is an inflammatory response. And with COVID, you may have heard of the cytokine storm, which actually ends up ultimately causing death. And cardiovascular disease, people who know they have heart disease or they have previous heart muscle damage. That's why we've all been warned to avoid being around the elderly, people who are at risk, because these people are most likely to develop disease severity and or death.
So this is trying to illustrate that. The picture on the left, when people talk about COVID, they generally talk about pulmonary complications, things that are going on in the lungs. But the virus can actually infect heart muscle cells directly. It does it through the ACE pathway, the angiotensin converting enzyme pathway, which many of you are familiar with because of the drugs used to treat hypertension that are ACE drugs. But this inflammation occurs, the cytokine release, and there's actually heart muscle damage. And that heart muscle damage can lead to acute complications, such as a sudden MI, or the long haul syndrome, which is a problem with left ventricular function where the heart is not beating as well as it should. It's generally appreciated as extreme fatigue that can go on for months, if not years. So the threat to your health is not just COVID affecting the lung structure, but the heart as well, resulting in acute complications such as sudden death or long-term problems that you might appreciate as extreme fatigue. So this illustrates the astounding hazard of having both COVID-19 and a heart attack. This was a study done in hospitalized patients with heart disease and those with COVID-19 and those without. And the percentage in red is illustrating the percent who died. And it turned out that if you were in the hospital with a heart attack and you had some complications, 44% died, but they did not have COVID. If you had COVID, 77% of those patients didn't make it out of the hospital alive. So the combination of the two is particularly disturbing. So some concepts of heart disease that we'd like to review now that you may or may not be familiar with.
The first sign of heart disease could be too late. And again, I know that firefighters know this more than anyone else. 50% of men and 60% of women who died suddenly did not know that they had heart disease, nor did they have any previous symptoms of the disease. This photo was taken from the Canadian Journal of Firefighters, where, as you can tell, they are resuscitating one of their own.
So why is this? Why can somebody suddenly drop dead from heart disease with no previous symptoms? And I'll try to illustrate that with this slide, which is representing an artery with the blood flowing down the middle from the left to the right at different ages. So way on the left, you might be young, like 20 years of age, and way to the right, you might be elderly, like 90 years of age. And we know that this disease process starts early in life, in your 20s and 30s. Something irritates the lining of the artery wall, fat infiltrates, calcium's deposited, and very slowly this process proceeds. And we used to think that you had to go all the way to the right where you see that very small lumen, and then you got your angina and you got a treadmill test and you were diagnosed with heart disease. But in the past 20 years, what we've discovered in cardiology is that most people have heart attacks who only have about a 50% blockage. And there's plenty of room for blood to get past so you don't have angina, but something irritates it, such as inflammation. And the fatty material that's in the vessel wall erupts a little bit like a volcano. And when it spills into the bloodstream, a blood clot forms very rapidly, and bong, you have a total occlusion, person goes down with a heart attack, and they may or may not survive. So this explains why 50% of people find out they have heart disease for the very first time when they suddenly drop dead. This concept is also important to appreciate in terms of testing we do to detect disease, one of which is a regular stress test that you have received probably annually in many of your exams. Every stress test in the world will be absolutely normal when you have a 50% blockage. You need to get to about 75% block before you get what's called hemodynamically significant, and you develop changes on your EKG that then tell you you have coronary disease. So the real way to use a stress test is to determine if you have symptoms, is it because of a partially blocked artery? But if your stress test is normal, it does not mean you do not have heart disease. It means you do not have severe heart disease.
So what we're trying to also illustrate here is that by these firefighter-specific heart health tests that we're going to be discussing in a minute, we can pick up disease at these early stages here. And we don't want to wait until you get down here to tell you that you have heart disease. So all of you are familiar with cholesterol test and routine cholesterol testing. And while we think that that is important to detect and treat, I want you to know that high blood cholesterol does not always identify those that have heart disease. In fact, 75% of people that have heart disease actually have a normal LDL cholesterol. So most patients don't actually have a classic cholesterol disorder. And we don't know this, Robert and I don't know this just from firefighting. We know this from our years in preventive cardiology. most risk of heart disease are associated with advanced and non-traditional risk factors.
So to drive that point home, I made this slide from a large study at the American Heart Association called Get With the Guidelines. It was done in 136,000 individuals coming into the hospital with a documented heart attack. So all these people are known to have a heart attack, and they measured the blood cholesterol, and in this case, the LDL cholesterol. And at the bottom on the x-axis, those are LDL cholesterol ranges. And just look at 100 for a second. And look at the red bar and go all the way to the top. That's about 10% of everybody had an LDL cholesterol of 100. And then to the left of that is 90, and that's about 11%. So if you add up the height of each of the bars, it comes out to be 100%. So look to the right of the yellow box, and that's individuals with LDL cholesterols over 130, which would be considered high. And therefore, that's a risk for them, and that's their problem. And cholesterol lowering should be aggressively achieved in those individuals. However, recently, it was felt that LDLs under 130 were normal. And if that's the case, 75% of patients who have heart disease coming into the hospital with a heart attack have, quote, normal LDL cholesterol. In fact, almost 25% have an LDL under 70, which is considered really good. So most people with heart disease do not have a classic hypercholesterolemia condition. Something else must be causing the disease.
So we know what some of those other risk factors are that are causing disease. So this is just a glimpse of what we're going to be offering for the cardiovascular disease risk markers. So Robert was talking about LDL being, quote, normal, but what you don't know is what the type of LDL or the size or the density. And most dangerous of the LDLs is an inherited trait called small dense LDL. We're going to be measuring that. Another concept that is less well understood, and I hope you will learn more today, is insulin resistance. Insulin resistance, catching it early, is when lifestyle, diet, nutrition come into play, and you can actually reverse that signal of someone developing type 2 diabetes. Lipoprotein A, or referred to as Lp(a), is also an important marker that now the national guidelines have said everyone should be screened for at least once. It's inherited, it's causal of cardiovascular disease, and most importantly, it causes an increased risk of blood clots. We're going to talk about that further. Another marker is Lp(PLA2). This is also known as a plaque activity test. This is an inflammatory marker, but it's very specific to that inflammation. If you think back to the drawing that we just showed you of the artery, when inflammation starts inside that arterial wall due to plaque being built up, because plaque's not supposed to be there. So that's an important marker. If it's elevated, we can guide you on what some of your considerations would be. Another important marker in firefighters is NT-proBNP. This is a marker of heart muscle stress and damage. It's an enzyme that's actually released from those muscle cells. This can happen over time, slowly, has no symptoms, but can also help us detect who needs to manage hypertension or who's already suffered a heart attack that they were unaware of.
So Brenda mentioned the small dense LDL issue, and this is something that's been researched for over 50 years now. But let me explain a little bit what it is. This slide reveals that on the left, an LDL cholesterol of 100 milligrams per DL could be represented by 5 LDL particles, but the entire 100 milligrams is distributed in those 5 particles. On the right is also somebody with an LDL cholesterol of 100, the exact same number, but they have multiple LDL particles that are small, and each one contains less than the ones on the left. But you have multiple small dense LDLs that infiltrate to the artery and contribute to premature coronary disease. This is a familiar trait, but also linked to the metabolic syndrome and issues that involve weight gain and weight loss. So this illustrates an inexpensive way to actually control this. So you might be thinking, well, what drug do I need to be on if I have this condition? And you might not need a drug at all. This was a study we did at Stanford University a few years ago. And we got a large group of people, and we got half of them to lose weight. That's the weight loss group. And half of them was the control group. They didn't lose weight at all for a year. They were happy about that. And you notice the LDL cholesterol went down almost exactly the same. That's why you have a control group. So no effective weight loss on LDL cholesterol. But look at the small LDL. It went down dramatically with an increase in large. So the total didn't change, but the type of LDL was dramatically improved with simple weight loss. So very often the most effective therapy for some of these conditions is actually the least expensive. So this relationship of small LDL to cardiovascular disease has been established over multiple years in very large federally funded studies that your tax dollars have paid for. So I just want you to appreciate that there are many, many studies now that confirm this. So if you're concerned about cardiovascular disease, this is one test that should definitely be done. And you find it in about 30 to 40% of patients with coronary disease.
So another concept that causes heart disease is insulin resistance. And what we're doing is offering a way to detect insulin resistance early on and not waiting till you are a type 2 diabetic to tell you that you need to make some changes. Insulin resistance, people with diabetes don't die of an elevated glucose. They die of a heart attack or a stroke. So Robert just mentioned that small dense LDL is closely related. We know this scientifically. On the chromosome number 19 are multiple genes that affect both the inherited trait of small dense LDL and diabetes. So by developing an insulin resistance, you are leading yourself down a path that is not healthy. High triglycerides play a part in that. You may have heard your physicians or on your lipid panel, someone say, well, you have high triglycerides. They're a little higher than we like, but not worried about it. It is a reason to be concerned. The other thing is hypertension. Hypertension plays a significant role in insulin resistance. And I've already mentioned type 2 diabetes and obesity. Elevated glucose leads to obesity. But again, the most important thing I want you to know is that by measuring an fasting insulin level, we can actually detect this insulin resistance way before a fasting blood sugar.
So one of the other tests we're going to measure is LP little a. It's lipoprotein lowercase a. It's a genetic issue. It's probably one of the most strongest risk factors for familial heart disease, for bypass surgery, and for heart attack. And what it is an LDL particle, as illustrated by this sphere with yellow in front of you. And the red snake-like thing is a protein called the B protein, which is supposed to be there. So that's your LDL particle that's filled with cholesterol. But that hair-like structure flopping off to the left there shouldn't be there. That's a protein called protein lowercase a or little a. And the curly Q's, think of it like a hair. And they're called kringles because oddly enough, they look like a Dutch pastry called a kringle. This is present in a third of patients with coronary disease, and you don't know you have it unless you measure it. This has been around for multiple years with recent guidelines that support the concept that everybody at least once in their life should have this measured.
So again, I'm bringing this concept to firefighters. Yes, everyone should be measured, but especially firefighters. Because it is causal and premature, testing routine labs, you're never going to discover this. But probably one of the most important things for the firefighter community is it's thrombogenic, meaning it increases your risk of blood clots. It's inflammatory to the blood vessels, and whenever you have inflammatory damage, heart vessels are weakened or damaged. It's inherited. First-degree relatives should also be informed. But most important too is it can cause aortic calcification, aortic valve disease. And that's why it's important to make sure that we guide you to have health monitoring.
So once again, you might ask yourself, what's the treatment for this? So I had to show this slide too, because it is so revealing. This is a large study called the Women's Health Study done in Boston that we were involved with when I was at Solera. And we were measuring genes, and the LPA gene is the gene for what we just talked about, LP little a. And this was an aspirin study. This was a study in which they gave half the women aspirin for 10 years and half the women no aspirin for 10 years. And the general conclusion was aspirin didn't make a difference. So perhaps people should not be taking aspirin every day of their life all the time. However, we analyzed the genetic predictiveness of using aspirin in patients with and without LPA. So if you look, there's two red lines. There's a solid red line and a dotted red line. And those are women that did not have the gene and were randomized to either aspirin or placebo, and they're almost identical. So that's true. For those women, aspirin offered no benefit whatsoever. But look at the blue lines. That solid blue line shoots up amazingly high. And that indicates that women who had this LPA, but were randomized to placebo, had a tremendous amount of heart disease. And now look down at the dotted blue line. Those are women who similarly had the genetic issue. They had Lp(a), but they were actually given aspirin and they dropped right back to a normal level. So this is an example of how using these tests can identify an issue that solves a problem. And the problem is, should everybody be on aspirin all their life? And the answer is probably no. But if you have high Lp(a), the importance is incredibly strong, and you should be on aspirin, just 81 milligrams a day, another simple treatment.
And this study has been replicated in men, in case you were wondering.
So the next thing is this Pro-Bnp issue, which is a measurement we use in cardiology a lot to determine stress on the heart muscle itself. And what I'm illustrating here is the importance of having a low Pro-Bnp, which is the dotted line, or a high Pro-Bnp in regards to survival and getting out of the hospital alive. So those are days of follow-up on the x-axis, and the survival rate is going up and down on the vertical axis. And if you have a normal Pro-Bnp, there's almost 100% survival rate. So that's a good sign. If your Pro-Bnp is high, as you can see, there's about a 30% survival rate. So the combination of COVID-19 and elevated Pro-Bnp can be really disturbing and something that you need to keep an eye on.
So now we're going to talk about the FEMA heart study that we did in Gwinnett County Firefighters. So we're going to highlight, it's a very long study, but we're going to hit you some of the highlights. The key scientific and published findings from the FEMA heart study, we found that approximately a third of asymptomatic active duty firefighters actually had evidence of heart disease by coronary artery calcium or CAT scan. We did over 500,000 different tests in these firefighters. The standard risk factors did not predict those firefighters that we identified as having disease by a coronary artery calcium scan. What we did learn is the advanced cardiometabolic test, the one that Robert has selected for this panel, correlated to the evidence of heart disease. Those included insulin resistance and increased risk for blood clots, as in identifying Lp(a).
So our most recent publication actually comes out of the Los Angeles Fire Department. And this was about a year ago. And we're just using this to illustrate that. But an issue here now involves age. And as you know, as you get older, you're more likely to have a heart attack simply because of age. But if you look in the lower right-hand corner, it's illustrating age on the x-axis of firefighters and annual death rates. And the brown lines, there's 3 of them there, are looking at the incidence of death when they respond to alarms or have emergency medical responses. And as you can see, there's an uptick at about 50 years of age. So the older you are, the more likely you are to have an event while you're performing those activities. However, the blue line is fire suppression. So that's actually on the line fighting the fire. And that's almost a straight line, which means that it's not only a risk for older firefighters, but it's a risk for younger firefighters as well. And in fact, other investigators have found that just after 18 minutes of fire suppression duties, it can lead to a sudden coronary event due to some of these issues we've been talking about in terms of blood tests. So in terms of the publications from the FEMA study, they're listed here. We just want you to appreciate that this has been peer reviewed, it's been published and presented at multiple medical meetings by invitation in the next slide. These are the abstracts presented at these medical meetings. So there's a lot more information that's going to be coming out and is not published in the initial publication, but supports what we're trying to do with the firefighter heart disease program now.
So we've mentioned heart scans, and I'm sure many in the audience are familiar with these tests. These are tests that you go to a CT imaging department, you lay on a table, there's no IV, you don't have to have fasted. It's a very quick scan. We did this in the Monterey City Fire Chiefs, firefighters, as well as in Gwinnett County and other communities. This is what you're looking at here is a CAC scan. So what you're looking at here is this is actually the heart muscle in gray. This is bone. This is the sternum. This is your backbone. And these are the ribs. The black area is actually the lung fields. So what you're seeing here is a normal heart muscle with none of the white bony showing up here in the middle, because the bone is actually filled with calcium. So if you look over here, you'll see an abnormal CAC scan. Again, you see the backbone, the sternum, but now you see there's white calcium deposits in the coronary arteries. This is how we have been able to correlate what equivocates to disease. So we don't want people to wait to have a heart attack to know that they have disease, but we needed some way to measure which of the tests equivocated to that of heart disease.
So the important things from this study is, number one, the coronary calcium scanning independently detects heart disease, independent of other factors. And in other studies, 53% of asymptomatic firefighters were found to have coronary calcium and therefore coronary disease. It's found mainly in older firefighters. So if you look at a 25-year-old firefighter versus a 55, the odds are the 55 will have more calcium. But it starts at around the age of 30, 35. Not only did they have it, they had more severe coronary disease compared to normal populations, non-firefighter populations. And there was no correlation found with traditional risk factors, just like we did in our study. The second thing is firefighters had more severe coronary disease. That was in a study of about 650 firefighters compared to 2,500 non-firefighters. They had more left anterior descending stenosis, and very importantly, the firefighters had more left main disease. This you might know is the widowmaker. So if the left main shuts down, it sort of lights out. So firefighters not only have more calcium, but they have more severe disease. And very importantly, just like number 3 in our study, there was no correlation between that disease and the standard risk factors. So this illustrates that from our FEMA study. If you look at the red CAC positive, those are the firefighters that did have coronary calcium. And in blue, CAC negative were firefighters that did not. And so you can see about a third were CAC positive, but look at triglycerides, HDL cholesterol, and LDL cholesterol in the two groups. They're identical. There's no difference in those standard risk factors. So 32% of active firefighters are found to have subclinical coronary disease, and the standard measurements of lipid profiles don't detect who has disease and who does not. What does detect is a couple things. Number one is body mass index. As Brenda has gone over with the metabolic syndrome, this is an important issue. And about 75% of the firefighters in Gwinnett County had a body mass index over 25. But below that are some of these more sophisticated measures. 58, close to 60% had the small LDL condition. A third had markers of inflammation. A third had insulin resistance. That's what Brenda talked about in terms of the metabolic syndrome. And a third had dramatic elevations in Lp(a) that we just went over. So while standard risk factors don't predict who has coronary calcium or coronary disease, these more sophisticated tests can be very revealing.
So now we're going to talk about what we've coined the vulnerable firefighter. Not every firefighter is going to have heart disease, and fortunately, most of them are not going to drop dead from a sudden coronary event. But how do we know who does and who doesn't? So you know vulnerable means you're susceptible to harm and you're in need of a special care and support. But how do you know which of those firefighters in your department are vulnerable? We've known since the Kale study back in the 1970s that sudden cardiac death accounts for 45% of all on-duty firefighter deaths. Fire suppression actually represents 1 to 5% of that annual working time. So fire suppression isn't taking up that much of their time. However, during that fire suppression, 30% of sudden cardiac deaths occur. The relative risk for sudden cardiac death is 10 to 100-fold greater during fire suppression compared to their non-emergency duties.
So this is a very recent study that was just published where they took firefighters and put them through a burn, an exposure. So this was at a training academy, and they measured their temperature, their heart rate, and over on the right, their EKG. So in gray is the time during the exposure, and on the x-axis is the total time and recovery time. And the most important thing is the EKG ST depression on the right. So they actually wore Holter monitor-like devices. And while fighting the fire, you could actually measure ST depression. This reflects potentially ischemia during that time period, also associated, of course, with rapid heart rates that you see on the left. So the identification of the vulnerable firefighter can identify those that are more likely to have this ischemic response while they're fighting fires and be at higher risk. But all these things, there's something you can do about them. That's the important point. You want to identify the vulnerable firefighter and then take the appropriate steps to make them less vulnerable.
So this is an illustration of the physical demands of firefighting. So what is it about firefighting and cardiovascular risk factors that are so important? So this creates what I've termed a perfect storm for a heart attack or sudden cardiac death. So we've already talked to you about, you may not know it, but you may have presence of these cardiometabolic risk factors. Then you take on the physical exertion, that alarm goes off, you throw on that heavy suit, you jump on the truck, your cardiac demand is increased. Then, most importantly, which is totally separate from other professions, you're exposed to heat, and that leads to dehydration. You're also exposed to toxic environments that can lead to increased cellular oxidation and inflammation. All of these combined can alter your blood chemistry and also increase your risk for stroke and heart attack. So what we've already talked about is that blood vessels over time become stressed and weakened. Your heart muscle can be damaged prior to these events ongoing. And then you can have a sudden rupture, as we showed you earlier, which causes a coronary occlusion, which leads to a heart attack or stroke or sudden death. Not every firefighter has the presence of these cardiometabolic risk factors, but how do you know who does and who doesn't? And if they're treated and appropriately, they don't ever have to leave that truck. That's not anybody's intention. The intention is to treat you and reverse these risk factors. So this is what the Select Well Firefighter Heart Health Panel includes. We've talked about basic lipids. That's your cholesterol that your doc does every year on you. We've also talked a little bit about insulin resistance. What we're adding to this test is insulin. Most providers don't check a fasting insulin. They just check a glucose. And as I pointed out earlier, a fasting insulin is a much earlier sign. We also measure hemoglobin A1C for those that are type 2 diabetics or diabetics and wanting to see if they are in that healthier range. Blood clot risk. Robert talked about the small dense LDL. Because these particles are so much smaller, they're stickier, they clump together much more rapidly. And then Lp(a), that genetically wired hair that's hanging off of it, makes those particles clot so much faster. Heart muscle damage, that NT-proBNP that can identify maybe you had a silent heart attack and you never knew about it. And then inflammation, a general marker of inflammation, but when combined with Lp(a)2, shows a significant increased risk for heart attack or stroke. And one of the tests we didn't mention today that we're also including is an inflammation nutrition balance test, if you will, measuring your individual blood levels of omega-3 and omega-6. Omega-3 is anti-inflammatory, omega-6 is pro-inflammatory. How do you know if you're getting enough omega-6s or omega-3s? We want more omega-3s than omega-6s in our diet. The National Heart Association has some recommendations about where your omega-3 level should be, but unless you measure it, you don't know. So the take-home messages that I hope we've delivered from our presentation is COVID-19 disease severity and heart attacks do share several cardiometabolic risks. If detected early, they can be managed and reduce one's risk of sudden cardiac death, heart attack, or chronic disease. Heart attacks and sudden cardiac death are much more prevalent in firefighters. You know this, but we know now that it's due to the physical demands, perfect storming with those undetected and untreated cardiovascular risk. The FEMA heart study provided evidence, as have other studies, that help identify approximately a third of your firefighter population are vulnerable. So why not detect them? So our heart health program was created to help you do just that, detect, educate, and we're here to provide that ongoing support to firefighters through education, health coaching. And I think that's the conclusion of ours. And now we will turn it over to Dr. Ettava in Greensboro, North Carolina.
Do we need to get out?
I think Kayvon, he's going to take the screen from here.
Good morning. Good morning. Thank you so much, Dr. Superko and Brenda, for that wonderful presentation.
He's showing.
I'm going to, hopefully you see, talk to you guys about the Select Well Firefighter program. And we at Select Well have partnered with the Superkos with the mission of preventing sudden cardiac events for firefighters. We at Select Well specialize in advanced laboratory testing and are fortunate enough to have the expertise of the Superkos to guide us on which tests best represent cardiovascular risk for firefighters. And thus, we've developed a program geared specifically for you. So the current, we at Select Well want to shift from heart risk to heart health. The current issues as represented in the presentation by the Superkos are that routine lab tests often miss firefighter-specific health risks. They don't have any value if they're not understood or acted upon. And there needs to be an optimal health and lifestyle in order to reduce that risk. We at Select Well are going to provide those solutions. First off, we offer a firefighter-specific heart health panel. We provide each individual firefighter with their individualized, HIPAA-protected personal report portal with a lab risk review and accessible medical information. And we customize each individual we empower each individual with a customized consultation with one of our experts to discuss those results. Here is an example of a firefighter's individualized health portal, which has been scrubbed of any HIPAA or identifying information that one individual firefighter might encounter when they're enrolled in our program. They have access to this via their phone, via a computer, and it's geared specifically for each individual firehouse, and so that it can accommodate the needs of that individual firehouse. So an individual would log in, and this is the page that they would encounter. You have your firefighter health risk assessment. You have your advanced laboratory results, which include all of the results, all of the advanced tests that the Superkos recommended for a healthy heart or a heart risk assessment. You have access to a result consultation. There is, of course, if there's any issues or concerns, and help desk that you can access. You can upload any personal information that you want so that you can consolidate your individual results. You can communicate with one of our experts via our communications center. You can share with your medical provider any of those documentations, give them access to your HIPAA protected information. These are all available in our individualized portal. If you were to click on your laboratory results, one of the key components of our Select Well program is to educate each individual firefighter of their individualized risk, heart risk, and therefore that they can make the necessary changes to improve their overall health. So if you clicked on the laboratory result, you encounter this page, which is the result page of those advanced heart risk markers that the Superkos mentioned earlier on in the presentation. In this portion of the lab report for Joe Firefighter, we are focused on small dense cholesterol, or SD-LDL, and lipoprotein A, the familial inherited genetic risk marker for heart risk. On this report, individualized report, you instantly get a glimpse of whether or not you are at risk, you are in the green, or you're borderline in the yellow. So if we look at Joe Firefighter's results, he started out a little red on the right. So you can see the history of the results over a year period. He had a high value of 62, and through some weight loss and guidance from our consultation, he was able to improve that over 6 months down to 51, and then finally into the low risk category, 41, improving his overall odds of not having a cardiac event. Again, if you look below, Joe Firefighter is at somewhat of a risk of that genetic variant of lipoprotein A, the crinkle that the Superkos were talking about earlier. This might not be enough information, just enough glance to indicate your risk. So we want to empower them with additional information. So on the left hand of the portal, you can see that each test has their own test explanation, the associated risks indicating what the impact of that test, whether it is at risk or low risk or borderline risk, would mean, and the considerations of what you can do or what advanced things you might want to consider to minimize that risk. And it looks a little bit like this. So for small dense LDL, when you click on test explanation in our portal, it will go into a detailed explanation of what small dense LDL is. Furthermore, you can look at the associated risks. And then on top of that, you can look at some of the considerations. So you are empowered as an individual firefighter with the education needed to make the changes necessary to minimize your heart attack risk. But we don't stop there with SelectWell. We know that it's important to have that human interaction and that detailed explanation by one of our experts. So we provide with every testing event a consultation of each firefighter's individual personalized results. And that's pretty easy to accomplish. So you click on schedule a result and you will get someone as qualified to go over each of your individual testing events and each result and what you can do as an individual to minimize your risk of a heart attack or sudden cardiac event. If there's any questions or concerns, feel free to call at 336-235-0750 or email at info@selectwell.com.
Thank you, Kayvon. I'm sorry, Dr. Ettava. We're a small team. It's been a pleasure to work with you. So this is the conclusion. Oh, that was you can take that one off. Robert was prepared to answer questions about COVID and we're in the different variants, but we're here. I'll say that all three of us can probably speak to COVID-19 if you have questions. Robert and I will be happy to also take any questions you may have about cardiovascular health or the program itself. So if you have any questions, please let us know. And I'm not sure how they let us know that, or does our moderator gonna read that?
Hey there, folks. Right now, I'm not seeing any questions that have come in, but just a reminder to the folks who are watching, if you do have any questions, you can just place them in the Ask a Question area, and we will give them to the team here. So, I don't know, folks, did you have any closing thoughts or anything while our audience considers?
Well, I want number one, each department to think seriously about contacting us and learning more, because Robert and I, like I've said, we've tried to travel across the country and give an opportunity to explain why you have heart disease more than others, but also more importantly, why those routine traditional tests don't work. We want nothing more than to help you. So please take advantage of calling us. We will have someone come to your department. We will reach out to you. We want to be here to help you. So thank you for your time today.
All right, so we do have some questions coming in. So again, folks, if you have any questions, we still do have a few minutes here. So we have a question from Alan who asks, is there any correlation with COVID and the new onset Afib?
Yes, atrial fibrillation is an irregular heartbeat, which you can think of as Gene Krupa playing the drums. It's irregularly irregular. It becomes quite common as we get older, and there's a specific gene for it that actually identifies high-risk individuals. That underlying propensity is exacerbated by any kind of stressful situation, such as COVID. So there's not a direct link between COVID and atrial fib that I'm aware of, except that the stress of COVID can exacerbate the underlying propensity and bring on clinical atrial fibrillation. I hope that helps a little bit.
Remember, we showed you that the cardiac muscle cells actually can be attacked. And so the electrical conduction has to occur within those muscle cells. So there can be a shared responsibility of genetics and also of COVID-19.
All right, so we got a couple more questions come in. We have Philip asking, he says, I saw a title titled Sharing Permissions. Can you explain that tile on the portal?
I'll take that question. And so when we want to make sure that if you wanted to share your results to a significant other or a medical provider, that you can give them access to your individualized health portal. So you can provide your physician with access. They can't alter anything, but they can view not only your health data, but they can log in and see your historical results of your advanced laboratory testings to better assist and guide you on your improved health journey.
There's a follow-up question from Philip on that, and he asks, what information does a fire department have access to on the portal versus individual firefighters and the information that the firefighter only sees?
So this is all HIPAA compliant, so only the individual get those results. The firefighter house does not get your individualized results. They will not be able to determine anybody's individual risk, other than maybe wide generic data such as the overall risk of a fire department with a large population. But that even then is not shared. It's all HIPAA compliant. All information is scrubbed at that point.
All right, we have a question from Josh who asks, does the NFPA recommend any of these additional blood tests, or are you working to get them added to the standard NFPA 1841, he believes?
Yeah, to my knowledge, it is not included in the guidelines, the national guidelines, and certainly working to get them incorporated would be appropriate, and we would very much appreciate wanting to do that.
All right, so just a heads up, folks, so we have a poll coming across, so please do answer that poll if you can. We have one more question as well, this one from Vincent, who asks, who comments that these screenings are very important, but as far as prevention goes, are there any studies on the impacts of a first responder's diet on cardiovascular disease? And do you provide health coaching in this area specifically?
Yes, and yes, and yes. You know, there is a firefighter diet that was written. It's a vegetarian diet, but firefighters eat together. They shop together for their food. And one thing I've learned after being in many firehouses is that they tend to eat comfort food. It's a lot of meat, a lot of potatoes. So they do not follow the healthiest diet, at least in the fire station. One thing that we did here in Monterey in Chief Panholzer's group was once everybody had to leave us because the alarm went off and we were in the middle of an education session, Robert and I peeked in the refrigerator and lo and behold, there was nothing healthy in there. So we went back and talked to them about cooking more fish and salmon. We live in Monterey, we have a lot of salmon. We've also talked to firefighters in Bozeman, Montana, who do a lot of ice fishing. So fish is an important component, but it's not an easy thing to always cook. We also recommend sometimes for individuals that they consider increasing fish oils in other ways. Did that answer your question?
Well, so let me add one more thing quickly. This is a great example because you notice we are measuring the fish oils, omega-3s in this study. And the same diet is not the right diet for everybody. So we measured fish oil levels in Chief Panholzer's group. And there were some people that had very high blood levels. They weren't taking fish oils at all, but because of their metabolism, they already had high blood levels of fish oils and do not need to supplement it. On the other hand, there were some people with really low levels, and we'd say, okay, now that's the subgroup that should supplement themselves with the fish oil capsules. So the same diet or the same exercise program is not the right thing for everybody. You need to customize it. And that's what we're trying to do here.
And to answer that last part of it, on our staff, we have a board certified health coach in which guides on not only nutrition, but sleep and physical activity, all free things that individuals can do to improve their advanced laboratory results. And that is a key component of our program.
All right, and one last question, quick one here from Stephen, who asks if there are any existing programs with fire departments that we could speak to.
Yes, Robert and I have, well, outside of the FEMA study that we conducted in Gwinnett, after that study was concluded, there was such an outreach of firefighters that wanted that we started a community screening at St. Joseph's Hospital, and we offered it, and it ended up spilling over to some of the police had heard about it and wanted to come in. So yes, we've done it there. We have done it in Arizona, Miami, Montana, California, several places in California.
So I think the answer to this, though, would be if somebody's interested in talking with people we've previously worked with, perhaps they should contact Select, because then we could call that department and say, is it okay if we refer this guy to you? So instead of giving you names and phone numbers, I think there should be some kind of filter. And does that sound like an appropriate thing to do? Have them call the Select? There you go. Kayvon, does that sound reasonable?
That's the idea. That way we can get your geographical location, pair you with up with one of your neighbors, someone that can speak to the program and how we are performing and what they like or not like about it.
Well, we'd also like to thank Chief Panholzer, who might still be on, I see there, for giving his time and energy to us today. Thank you, Chief.
You're welcome.
All right, well, I mean, I guess we're going to wrap it up. Thank you all for presenting, all this information and sharing your expertise. So don't forget, folks, that this presentation will be archived within 24 hours, and you can get to it at our homepage at fireengineering.com. It'll be up there for a year, so if you want to rewatch, please feel free to do so. We'll send everybody a reminder email message with a direct link to the archive. So thanks for joining us today. Yes.
But there was one last question that I wanted to address
oh, yeah,
from
absolutely.
Philip about what resources do the fire department need to provide versus the resources Select Well would provide. We are a nuts to bolts operation. There is no resource that the fire department individually needs to provide, though we are also willing to work with whatever infrastructure that will resist. If you have a medical officer that wants to be involved, Brenda and Dr. Superko are excellent educators on the advanced laboratory testing that we provide. If you have a team of phlebotomists, then we'll gladly use whatever you have there. But again, we can come into any fire department, no matter how rural or urban, and provide all the necessary components in order to accommodate the program.
Awesome.
Thank you, everyone, for your time this morning.
All right, thank you all, and we'll catch you next time.
Bye-bye.
Bye.
Bye-bye.